think we're live. Yes. Oh, we have 8 participants. Bob, should I start or give it 2 more minutes?
Maybe give it 1 more minute, and then we'll start.
Thank you to all of the very prompt attendees. I'm very impressed.
Okay, I think Manusha, you can go for it.
Sure. So thank you everybody for joining in. This is fabulous, and thank you to the panel. Also, I know it's early morning for some and super late night for others. So thank you for that. This webinar episode is to kick off the consortium's webinar series called Making Comprehensive Primary Healthcare a Reality in Low and Middle Income Countries. In this session, we're going to be talking about how do we move from selective primary healthcare to comprehensive primary healthcare in low and middle income countries. And we have this panel which represents different regions of the world for you, and we're going to be having some interesting discussions. But before we jump into that, I want to thank the Primary Healthcare Performance Initiative because of the micro grant they gave us. We were able to organize and host the series. A little bit about the consortium. We are a global primary healthcare research network led by organizations based out of low and middle income countries. We conduct prioritized policy relevant research to support country and global efforts to build high quality primary healthcare systems. You can read more about us on our website at phcrc.world. Some housekeeping announcements. So for your questions, we welcome your questions through the session as the discussion is happening. We want to keep it engaging and live. So use the Q&A function that will help us monitor all your thoughts. And I'll also share the link for a Jamboard, and you can use that as well. Engage with us live on our Twitter handle. It's care_PHCRC. We have been running a small social media campaign on evidence-based primary healthcare. Do join us with these hashtags: primary healthcare, hashtag stronger with PHC, hashtag evidence-based PHC. With that, over to Bob to start the session.
Okay, well, great. Thank you, Manushi. So today's webinar is really going to be more of a panel discussion and an engagement with your questions and comments on the panel discussion, as opposed to like a lot of PowerPoint presentations. And the key question that we are going to be debating with this panel, who I'm going to introduce just now, is how do we move from selective primary healthcare to comprehensive primary healthcare in low and middle income countries. So that's sort of like the central question. And then we've unpacked that into 3 sort of sub questions, which the panel will debate. And then at the end of that little debate on each question, we will then have a look at your own questions and comments and have a look at them and discuss them before we move on to the next sub-question. So that's the plan. Now, let me introduce the people on the panel. Okay, and now I guess I need to introduce myself. Let's get this up in front of me. There we go. So before I introduce the panel, I'll introduce myself. My name's Bob Mash. I am actually sitting in Cape Town in South Africa, and I chair the steering committee of the Primary Healthcare Research Consortium, and I am a professor of family medicine and primary care in South Africa. So, and then let me introduce the other panel members. I'm just going to go on my top left here. We've got Praveen Devasetti. So Praveen is sitting somewhere in India. I'm not quite sure exactly where you are in India, but somewhere in India. And Praveen is the coordinator of the sort of core of the Primary Healthcare Research Consortium. And he heads up, he's the program director for primary healthcare research at the George Institute for Global Health, and as a sort of public health specialist. And I know he's worked in a number of countries like Indonesia and Bangladesh and Thailand, particularly around sort of M-Health initiatives and so on. So that's Praveen. Welcome, Praveen.
Thanks, Bob. And I am from Hyderabad in India.
Hyderabad, yes, excellent. And
Thanks,
then
Bob.
let me come down my bottom left. We have Lisa Hirschhorn, who is sitting in the United States of America. I think she's in Chicago. Is that right, Lisa? You're sitting in Chicago?
Yes, yes.
So close to Chicago, and she's probably just got out of bed about 10 minutes ago and had a cup of coffee. But Lisa, yeah, there it is. Lisa is professor of medical social science and psychiatry and behavioral science, it's quite a mouthful, at Northwestern University Feinberg School of Medicine. She's also on the steering committee of the Primary Healthcare Research Consortium. I think her background, putting it, is sort of summarizing it, is probably a little bit more in infectious diseases, but she also is a big expert on implementation science. And I see she's been working quite a bit with the Global Alliance on Chronic Diseases recently. So, okay, so that's Lisa. Welcome, Lisa.
Thank you. Lovely.
Okay. Then we have Emma Riate, who is joining us from Latin America. Where are you sitting in the world, Emma? Actually, right now, where are you?
I am actually in Panama in a field mission.
Okay, so you're joining us from Panama. Wow. Okay, so that's fantastic. Now, Emma is the chairperson of the advisory committee for the Primary Healthcare Research Consortium, but she also chairs an advisory committee, I'm probably going to say this wrong, of the Salud Mesoamerica Initiative, managed by the Inter-American Development Bank. But in essence, I think what she's doing is she's helping to lead primary healthcare programs in different countries within Latin America and the Caribbean. And she's got a lot of experience in that part of the world at quite a sort of macro level. So welcome to Emma.
Thank you.
And then finally, we have Rohina Joshi, who, where are you sitting, Rohina? Are you in Australia? Have I got that right?
That's right, I'm in Sydney, Australia.
Okay, so she's in Sydney, Australia, and she actually is working on she's leading one of the research studies for the Primary Healthcare Research Consortium, which I remember rightly has been looking at comprehensive primary healthcare and the relationship to the different ways we formulate primary healthcare teams. I think that's right, isn't it? And you're also a public health physician with an interest in low-cost healthcare models for chronic disease management. Are you originally from Australia, Rohina?
No, I'm from India, so born and raised in India, did medicine, public health, all my training in India, and then a
Okay, so
PhD from Australia. Yeah.
right. Okay, so you've got a good background in India and other low and middle income countries. Right, so welcome, Rohina. I hope I've done justice to you all. So now let us go to the first question. Now, before we get stuck in to the big question, we actually need to really understand these concepts. We've sort of framed this discussion as how do we move from selective primary healthcare to comprehensive primary healthcare. But I think we need to start by saying, well, what do we actually mean by this? What is selective primary healthcare versus comprehensive primary healthcare? And I think I'm going to come to Praveen to start, help us with starting to answer that question, and then the others can also join in.
Yeah, thanks, Bob. Well, according to me, primary healthcare was actually intended to be comprehensive, not selective. So when we talk of primary healthcare, of course, it's comprehensive primary healthcare, which not only caters to healthcare diseases, but also covers food supply, nutrition, safe water, basic sanitation, and health education. But over a period of time, because of the ease of implementation, because of the cost, and because of easily attainable targets, the approach kind of changed, focused on a selective version of the primary healthcare, and which is we are calling as the selective primary healthcare. So this selective primary healthcare, is based on advocacy around prioritization of conditions which are of utmost importance. And when I say importance, it's based on high prevalence, morbidity, mortality, and of course, considerations of only interventions that are of proven cost effectiveness. Say, for example, when we talk of growth monitoring, oral rehydration therapy in childhood diarrhea, breastfeeding, immunization against common childhood diseases, and so forth. So when we start using the selective interventions and selective models, the outcomes become more visible, and we get a measurable effect on the survival when compared to the expensive and complex, so-called complex comprehensive primary healthcare. But over a period of time, due to the changes in epidemiology of diseases, increase in burden of diseases, increase in non-communicable diseases, structural, political, and economic challenges, there were major implications to health systems delivery using selective primary healthcare facilities. Say when the levels of malnutrition increased, or other conditions, new diseases such as COVID or any other disease conditions sort of arose, the selective primary healthcare approach, which trained the health workers to have a vertical, narrow approach to assessment and treatment of diseases, was not found to be sufficient to manage this huge burden and multivariate factions of diseases. So the selective primary healthcare, it started to prove more expensive to implement than which it was previously anticipated. Again, each disease focus has its own structure, say organizational structure. It has its own training, supply, storage, distribution, and reporting system. So because of all of this, it was difficult to provide the comprehensive care. And apart from this, due to poor infrastructure, water, sanitation, other issues, the role of food, mainly in disease. So this sort of promoted the persistence of high morbidity and mortality, minimizing the impact of the vertical intervention. So the comprehensive primary healthcare, according to me, encompasses both curative, preventive, and promotive aspects of healthcare. It addresses the population as a whole, not as population subgroups. It seeks to strengthen the healthcare system in a more sustainable manner, of course, with community participation, and it requires a lot of intersectoral coordination. So that's from me.
Great. So thanks, Praveen. So I'm going to see now if anybody wants to sort of, I mean, you've given us a great sort of definition of selective primary healthcare and a bit of a critique as to, in a sense, what's not so good about it, having all these vertical programs. But I get to see, I mean, what though do we, I mean, you've started to sort of speak about what we mean by comprehensive primary healthcare, but maybe we can also elaborate a bit more on that. Let's see, Emma, what do you want to add anything to what Praveen has said, and maybe say a little bit more about how you understand comprehensive primary healthcare?
Yeah, thank you. I think that it's important to highlight here the relevance of the multidisciplinary teamwork, also the community participation and engagement, and the intentionality to address the social determinants of health at higher levels of the government, but also at the subnational, municipal, and local levels, and making sure that services cover everything, since the primary first level of attention to the tertiary level of attention, but also including rehabilitation, treatment, prevention, and promotion. I think this multidisciplinary, multisectoral approach with a focus at supporting and strengthening local capacities and subnational capacities, including intercultural issues, yeah, that usually in fragmented and selective primary healthcare approaches are not present, are really, really important in terms of make services more efficient, more effective, and that provides us the possibility of attain higher health and improve health status of the populations. Because the issue is that, you know, most of the countries, especially in Latin America and in the Mesoamerican region, for example, are working since the last 50 years in very fragmented vertical programmatic way of working. And that means different planning, different line item budgets, different ways of monitoring and evaluation, different set of indicators and different approaches to consultation with community or whatsoever non-community participation in consultations and including accountability issues. I think that is bringing us to very fragmented and temporary, we can have like some temporary gains, but those gains based on disease approaches, centered on diseases, are not sustainable and are not, you know, give us guarantee that more cases and diseases will happen, because it's a disease focus and not a health approach.
Right. Yes, no, thanks. I mean, I think in Africa, people have started talking about inequity by disease because of these vertical programs. You know, so there are some patients, for example, with diabetes who kind of wish that they had HIV, because at least then they would get a lot of resources for their particular condition, you know. So yes, Lisa, I think you wanted to add something to the discussion.
No, I think this is a really important discussion. I just want to sort of highlight, and thanks, Karen, for noting this in the Q&A. I think the whole point is that selective primary healthcare by definition is not primary healthcare, but there's a very long and established history, and want to just sort of quote from another very important comment that somebody put in, which is sort of, why did selective primary healthcare emerge? I don't think it was because people thought it was the best option for everybody, but that there was a lot of both political and economic reasons behind that, in the sense of where people were willing to invest. And I think there's been a lot of appropriate pushback on the fact that this was not the right direction to go, and really, unfortunately, I think is to some extent still reflected in the way that if you look at sort of where donors are going, I'm going to get to the vertical versus integrated, having been in one of the most vertical programs from HIV, but the idea that, you know, if you look at sort of where funding is going, I think it's only recently been really emerging as going towards comprehensive primary care, one of the critical 4 C's. But at the same time, and I think as Emma, as you very correctly pointed out, you know, we shouldn't forget some of the other C's, which includes continuity and coordination. which is what's needed when we're going from integrated, vertical to integrated. And the idea of really comprehensive primary care as the platform onto which somebody who comes in who has, a person is not a disease. It's not somebody living with HIV. It's somebody who has multiple issues. And it's only through this combination of comprehensiveness, but let's not forget the continuity and the coordination that's needed, that's often not able to be done through these vertical programs. So I would argue that as we luckily are sort of switching to this idea of comprehensiveness, that we also have to think about how that needs to be adapted for each country. And similarly, how donors need to then respond to sort of what are the additional infrastructure and training needs that needs to happen to that, and how do we make sure that it's not comprehensive within the vertical program, but actually comprehensive overall. So just wanted to sort of call out and thank Karen for bringing that. Completely agree about this idea about is selective primary care actually an oxymoron, and also the real reasons for selective primary health care, and why we desperately need to continue to push to move towards true comprehensiveness. Thanks.
Thanks, Lisa. Now I was going to see if Rohina, is there anything you want to add to what?
Yeah, well, a lot of amazing, fantastic points have been made. And I think just pointing on two of those, one around the social determinants of health, and the second thing around funding models. And I think that's the underlying cause of where money goes and what governments can fund in terms of primary healthcare. Just in terms of selective, I wanted to add another point. We've talked about diseases, we've talked about the range from prevention, promotion through to rehab, but also selective primary healthcare in terms of what section of the society is primary healthcare delivering to. Is that across the entire population, or is that also quite selective in terms of who can access this healthcare, especially when we talk about workforce, when there are no doctors, when there are no nurses, when there are geographical, difficulties or challenges in terms of people accessing healthcare. So comprehensiveness, yes, absolutely, the definition is right, but in reality, and I know we'll go down that path of what does it mean for that equity. And Bob, you raised a really good point of people saying, if I have HIV, I can get access to all these other conditions. But I think that going into that mode of saying true comprehensiveness, we shouldn't forget the people who need that access to care. Thanks.
So great. So, I mean, if I can summarize what I think you're saying about what is comprehensive primary healthcare, I mean, you've mentioned that it should be across a spectrum, right? From promotion, prevention, curative, and I think Rohina, you just added sort of palliative and rehabilitation, right? So it's a broad spectrum. It should be, I think, as you're saying, for the whole population, and there should be equity in the access to primary healthcare. And I guess that's what you are implying there, is it should be for the whole life course, right? So it's from, conception to death, basically. It's the whole gamut. You've also emphasized that it's very important that comprehensive primary healthcare also includes strong community participation and engagement, and a strong multi-sectoral action and attention to the social and environmental determinants of health, and not just the sort of the manifestations of that in terms of diseases. And I think Emma also mentioned that to do this, one also needs a multidisciplinary team of people. So I think that's what I've written down as some of the key things that you've said. Now, coming to the questions in the questions Q&A, Jeff Markhams has asked an interesting question. Now, I know Jeff. He's from the Primary Healthcare Performance Initiative in the United States, and also I think quite involved with family medicine. So he made quite an interesting comment here. So he's saying that he was on a webinar just now with quite influential American legislative staff members who are involved in global health funding. And when they were asked about comprehensive primary health care, basically kind of boiled down to the fact that they're probably not really investing in integrated comprehensive primary healthcare, but in a series of vertical programs, like HIV, as we've mentioned. And the response that came from these legislative people was that comprehensive primary healthcare is too expensive, and you then have to harm important programs like HIV if you put money into comprehensive primary healthcare. And this seems to be a common attitude amongst donors and investors and global health funders. So his question is, how do we change this narrative?
Can I attempt that? I'll try and be brave to attempt that.
Yeah.
I think not providing comprehensive primary healthcare to populations is expensive. I think we need to start with that. And the other thing being, there are so many funders and everybody providing, funding for certain elements. Why can't the funding be pooled at the country level and strengthen primary healthcare as it should from where the country, of what the country understands comprehensive primary healthcare to be, training health workforce, making medicines or, the policies actually come alive. Countries have amazing policies. They're just the problems are with implementation. So could USAID, could the big funders come to countries and say, we have got X million dollars, we would like to fund workforce, or another one says we would fund medicines. Could that be a way forward? And absolutely have accountability in that, and have all the tick boxes that countries need to, or NGOs need to respond to. But would that be a potential model for us to work towards? Thank you.
So I don't know whether you saw, it must have been a year or so back, that in the WHO bulletin, they published an article launching this 30 by 2030 campaign. And their angle is that funders should routinely allocate at least 30% of their funding to strengthen health systems and health services in the kind of cross-cutting way that you've mentioned, as opposed to vertical programs for specific diseases. Not sure how much traction that got. But anybody else want to?
Bob.
Emma, and then Lisa. Oh, I don't know who was first. Emma, let's hear from you, and then Lisa.
Yeah, thank you. I think in this narrative, also the discussion and the confusion between comprehensive primary health care and health system strengthening is important to be discussed as well, because it has such a bad reputation, the health system strengthening work, during the last years. And the issue is that what the problem I think is that it's easier to work in fragmented, isolated, vertical programs. That is easier. It's easier for donors and probably for some institutions like the one I work with, or other kind of institutions in working on international cooperation. But the problem is that we don't know how to support countries to integrate all these vertical actions into comprehensive operational ways of doing this. Because we forget that at the end, regardless of how many programs we have, at the end is one health providers team, community health worker, physicians and nurses in the local levels, receiving information and requests and reportings and mandates from different programs. This is almost impossible for this health team in a geographical area to comply with everything from quality coverage, norms, compliance, and outreach, and etc. to different donors, different fundings, and different programs. The issue here is how to make sure that we support countries not to put things together in a way of coordination, but to plan from an integrated perspective, everything, the design, the operational schemes, the funding way of executing the financing, and also the reporting and the indicators. And it is possible. And I think we will be able to provide some examples during the rest of the webinar.
Great. So on this question, I'm giving Lisa the last word.
Yeah, I think really, there's been a tremendous amount of really great questions, and we're going to sort of continue to answer them as they come through, including one which talks about what do we know about research funding, which is going to be one of the ways that we're going to actually know this. I think, in retrospect, as was pointed out by Sita, that the 3-1 concept, which was sort of done, particularly in the area of not just HIV, but sort of vertical, didn't really work, because I think that donors still had their, who are they answerable to? And I think I'm sort of cautiously hopeful that the WHO framework, which really tries to bring together more comprehensive metrics, if we could get, people to sort of understand what is success. To be perfectly blunt, if I wanted to achieve the most viral suppression at the cheapest cost, I would do a non-integrated vertical program that only focused on HIV. But I think as we really put this in the context of universal health coverage and sustainable development goals, and recognizing that having a single endpoint, whether it's mortality or whether it's viral suppression, is actually not going to get us where we need to be. It's really looking at this, moving beyond, even for under 5 mortality, beyond alive to alive and thrive, identifying the adolescents who constantly get left out of primary care, and the aging population, that the epidemiology needs to change. But we as primary care providers, as researchers, also need to figure out what is the evidence that is actually needed to continue to sort of get the people who are doing the funding to understand why. And to quote a particular comment, that too expensive is an oxymoron, which is, again, this concept of health rather than disease. So I think this is really, really an important, very important thing. I just want to also, just before we move on from the definition, to just bring up something that Amit Khanna put in, which is that we've defined comprehensive primary health care as really wide, all encompassing from birth to death. But this is very utopian, considering the resources are limited. Governments and funders will have to prioritize and identify the areas with the biggest burden. Being realistic, verticals will be chosen over comprehensive. Is there a way to optimize and integrate the vertical-based approaches better? And I think that's probably one of the most important things, which is how do we effectively, what are the strategies, implementation strategies that are needed to actually do that type of integration? How do we recognize that vertical is ultimately inequitable? Because, for example, you can't have these vertical programs in the most rural or difficult to reach areas. And again, I think for me, it goes back to how do we actually really think carefully about what is working and why, and how do we actually replicate that in other areas? And what is the sequence in which people need to do that? And how do we measure? How do we then measure success? So I think this is a really important component, and there's a number of other very important questions here, which I think we will get to in the next question. Thanks.
Great. Yes, and thanks for keeping your eye. It's difficult to listen and keep my eye on the questions all at the same time. I'm going to move on to the second question, so essentially what we've done is I think we've fairly clearly defined what we understand by selective, and we fairly clearly defined what we understand by comprehensive. And then obviously the assumption in this discussion is that we want to move from selective to comprehensive, that somehow comprehensive is better. And so the second question is, okay, so historically, yes, we've had this problem of very selective primary healthcare, the GOBI, FFF, and all these vertical programs for different diseases and so on. But is it still like that? I mean, we know that governments have been committed theoretically, right, to implement primary healthcare. We had the Astana Declaration a few years back. Is this still an issue in countries, or are countries actually moving into comprehensive primary healthcare? How big a problem really is this that we're discussing today? And I think I was going to ask Emma to address that question first. So, yeah, over to you.
Yeah, I think we all embrace the comprehensive primary healthcare approach, but it is, as I was saying before, it's not easy to get it functioning, to get it operationalized. In leadership, governance, and finance of the systems determine a lot the way countries implement their strategies and plans. So if these strategic aspects are not taken into consideration, are not changed, are not shifted toward other ways of the governance of the actual system, it's really difficult to operationalize the comprehensive public healthcare approach, because everything is determined by that. Yeah?
What's the situation, Emma, in Latin America? I mean, when you look at some of the countries there,
I can provide some examples. We had Panama, the whole region, had funding through one initiative with the Inter-American Development Bank to reduce maternal and neonatal mortality. And we had funding for maternal and neonatal activities. And we went to Panama, indigenous populations, 50 islands where they live, very isolated, rural, and hard to reach areas. And we were discussing all these strategies and interventions, and these communities didn't have any water or sanitation systems. So it doesn't matter what we are discussing, about maternal and neonatal strategies, very, evidence-based interventions, if they don't have any water and sanitation. That's because we are not considering then the social determinants of health or the multi-sectoral approaches. Another example, in indigenous populations in Guatemala, there are no roads neither roads or transportation, and still postpartum hemorrhage is a cause of maternal deaths. So those are the consequences of still being implemented selective primary healthcare approach. I think countries are moving towards that. Donors' contributions and cooperations in Latin America is less than in other regions of the world. However, that is really important because for accountability issues and for reputation issues, and are still, this cooperation is still very selective primary healthcare approach, and that needs to change.
Thanks. So Praveen, I mean, maybe Rohina as well. I mean, what's the situation in India and sort of surrounding countries?
Right. So, I mean, again, with the ease of implementation and with the targets that we need to quickly showcase, both in terms of the government and the funders, I mean, the approach was slightly shifted to selective primary healthcare, and to be modest here. So in India, we actually started the National Health Mission, which is the country's flagship health system strengthening program in 2005. And this program was particularly for primary and secondary health care. And in the earlier phases of the National Health Mission program, it was mainly targeted towards reproductive and child health and the increasing burden of communicable diseases such as tuberculosis, HIV/AIDS, and vector-borne diseases. So because of this focus for the last 15-17 years, of course, the indicators related to reproductive child health and select communicable diseases, we were able to come down, we were able to control those diseases. But again, as we have just discussed, this led to a manifold of other diseases. Say, for example, non-communicable diseases. There is an increasing burden, increasing mortality, increasing cost, because of NCDs. And then, there were other innate challenges also, which this NHM faced, which was mostly because of the narrow range of services, the infrastructure, which was not sufficient, the healthcare, providers, and there was a shortage around this, less of focus around the lack of, medications and diagnostics available in the primary healthcare, and of course the limited referral services. So this was present, but again in 2018, with the launch of the National Health, the program called as the Ayushman Bharat in India, we did try to, solve some of these issues which were raised in the National Health Mission, which I can be discussing later on.
Oh, great, thanks. I mean, I'll come to Lisa just now. I'm just thinking about my context, which is of course in Africa, and in South Africa actually has the largest, ARV program, I think, in the world, and it has been a massive vertical program, and in many ways quite successful. But we are now trying to move towards integrating that verticalized program, into a more comprehensive approach. And of course, what it means is there's tons of money for HIV, but literally, if you have diabetes, you're going to struggle. And so ironically, diabetes is now actually the leading cause of death amongst women in South Africa and not HIV. You know, when we look at, people sort of look at community health workers in our context through the lens of, you know, like, oh, what are they doing for HIV? You know, what are they doing for TB? What are they doing for this or that? But they come up essentially with the same problems, because the problems are actually problems of health, you know, the constructing the health services around training, around supportive supervision, around equipment, you know, all of that. So they're transversal problems, but they're not being looked at from a health services point of view, but through these lenses of different diseases, which is also kind of unhelpful in a way. Lisa, what's your take on this? Is it still a big problem?
I mean, I think it is, but I think it's, you know, perhaps we've moved in some ways a bit beyond where we were when it was, you know, just selective, and we've sort of become somewhat selective primary care, which again, you know, does that make it true primary care? Been sort of reading through the comments in the Q&A, which are really, really important in terms of what some of these challenges are. And I think there's an interesting tension even that I'm reading between people who are sort of saying we need to get broader. So the part of the problem being that we're too biomedically focused, and granted, I am a medical doctor, so that is certainly where I was trained, versus people saying, look, you know, COVID already took huge hits at primary care. So do we need to go for comprehensiveness, or just do we need to strengthen primary care, which I would argue is probably exactly what we're talking about, which is that when we're strengthening primary care, if we just decide to go back to selective primary care and strengthen those, I think we've really gone back decades. So I think it really is a thing about, and this is this concept of resiliency, which is providing good care in good times and bad. It's not just going back to where you were before. And this being therefore an opportunity to say, okay, how do we build back in a way that actually addresses the needs of the population? And I think the other thing is, which I agree with, is this cannot just be in the health sector, but how do we do this as an interdisciplinary approach? So if you sort of say MDs are responsible for, you know, the broader integrated people-centered healthcare approach, I think we're going to fail. And so I think it's this idea about how do we actually create that type of multidisciplinarity that's needed for example, addressing water and sanitation at the same time that we're addressing sort of the acute prevention and population needs. And I think we're going to talk about this more later, but again, there's coming up these really important themes about data. So Bhumika, and I apologize if I've just destroyed your name, talked about the fact that vertical program is expensive in terms of manpower or woman power. Trainings and comprehensive would require more infrastructure, multi-skill training approach, and more HR fortification. How do we financially compare the two approaches? How far the existing manpower can be trained at primary healthcare level to make it comprehensive? Very good point, because in some countries, the idea is just give more to the community health workers, and that's not actually working. And similarly, Pietra van der Homburg, who said, why is it so difficult to show that comprehensive primary care with sufficient personnel and leadership is a business case? And I think it's a real call to action for, regardless of the hat you're wearing, whether you're an implementer, whether you're a policymaker, whether you're a researcher, which is, what is the evidence that is needed and by the people that need to make these decisions? And what is what I call perfectly rigorous enough data that will show us, and how do we actually articulate that in a way that will actually drive forward not just the evidence of why it works, but also how it works. And there are certainly some, this was an earlier comment about what are examples of comprehensive primary care that seem to be working in low and middle income countries. And Emma, I'm sort of looking at you, because I think some of the best examples may actually be emerging from Central and Latin America on that. So sorry, a bit long-winded, but really was.
Let's come to Emma just now, or anybody else for that. I just want to see if Rohina wants to add anything before we try and answer your question. And then Manushi, can you be ready if there's some questions on your board that we need to address? Rohina.
Yeah, thanks, Bob. I just wanted to talk about workforce from that perspective of comprehensive primary health care, wherein countries were starting or they were trying to train up their health workers for the other conditions like, you know, high blood pressure or diabetes or cancer. But community health workers who face all these people on a day-to-day basis were already responding to people's needs without being trained. Now, in terms of a model, I look to Ethiopia, which one of my colleagues, Dr. Tassima, is doing her PhD on that, where she's worked with, try to understand and unpack how community health workers, their role in non-communicable disease control. And while there is a specific program, and Ethiopia actually takes the lead in the whole community health worker program and embedding that in a people-centered model, but within that implementation as well, there are huge gaps. So in the best of our examples now, there are issues with the training provided, the supervision provided, and of course now with the crisis in terms of the Tigray region, all that progress has gone back so many years. So I just want to kind of also bring in this, what war and COVID has done to primary health cares and the workforce that was progressing in that direction of going from, from this perspective, it's diseases from, maternal and child health, that acute care, to this, including non-communicable diseases on the agenda, and the impact that has had on the workforce. So just wanted to draw that into our discussion because as you rightly said, everything then goes on to dumping it on the community health worker who is not supported.
Yes, but you're making an interesting point. At least the point that I kind of taking away from what you said is that, even if we train our primary care providers in a sort of rather verticalized way, once you're on the front line in the community, I mean, the community don't make those distinctions. They're going to come to you with all their problems, and then you're unprepared actually to handle them. I mean, a good example from South Africa is, in one of our local districts here, stroke actually is a major problem, and people tend to only spend like 3 days on average in hospital, and they're sent home sometimes to a very informal shack or very basic house where they have no access to healthcare other than the community health worker, who is then visiting and is like looking at this desperate situation and not really sure how to help, but are being the only healthcare worker that's actually in the place, so you have to then equip them with some skills, don't you, to help the caregivers and do something to try and alleviate the situation. So yeah. Manushi, are there any, I can't see the board, but maybe there are some things that we need to address from the board?
Yes.
Manushi? Yep.
Yes. Let me quickly share the screen. Yeah. Is my screen visible?
No, not yet.
Now?
Nope.
No. But maybe you don't need to show it. You can pick out one or two of the key questions for us to address.
Yes.
There we go.
Please give me a second. Yes. Yeah. Okay, so there's a note that says, along the lines of Rohina's comment, I've never understood why ministries of health allow donors to select the topic. Ideally, the MOH should have a master plan of what each community division state needs most.
So I think it's an interesting and a very important thing. We did a pretty extensive work looking at sort of countries that were able to drop under 5 mortality more broadly and than sort of would have been expected given their financial resources and their regional peers. And there were 6 that were chosen, not because they were the only 6, but for geographic, and included countries like Nepal and Ethiopia and Rwanda. And we were able to find a number of sort of cross-cutting strategies and contextual factors. And one of them was donor coordination. And it seems like such an obvious thing, but it actually turns out was not that easy for them to do, and really required very strong leadership, a culture of sort of data and evidence use to inform and drive policy. And therefore, I think this idea that you're not actually just providing, the medication or the building, but actually investing in this longer term. And there's, again, a lot of discussion by the panel as well as in the Q&A about, about caring for the healthcare worker. And this idea that, and we certainly saw this even in these exemplar programs, and just sort of people are interested, I can look and find the link to the case studies, that you can't just add things on. And so recognizing what is the training and what is the staffing that's actually needed for this type of comprehensive care is really absolutely critical. Provider burnout is a very, very important thing that we need to all address, regardless of what the income is of your country, and really sort of think carefully. So I think this idea about how can countries really sort of move beyond the project, move beyond the vertical, really takes that kind of leadership. And I think there are countries that have lessons that they can teach in terms of how that actually needs to happen. And I can put the link in the, actually I can put it there, and then I think Manusha, you're going to need to put it out for everybody.
So before we move on to the next question, I remember you just reminded me that we were asking Emma to say, are there some good examples of countries in Latin America that are doing quite well with comprehensive approaches to primary healthcare?
Yeah, and I like to share the screen.
Okay.
Please
Oh,
let
yes.
me know.
Costa Rica.
Okay, Costa Rica, this is one example. Yeah.
That was the country I was thinking of, but I didn't want to lead you there, Emma.
Tell us about Costa Rica. Yeah.
There are a couple of issues after Lisa's comments, in line with Lisa's comments. In addition to resilience, I think there is a matter of quality and inequity issues, and not only in Latin America, but in other regions. Yeah, we are doing well in coverage, but not in quality in general. And also it's the Central American countries with this Salud Mesoamerica initiative. We made some agreements with the donors. First, there were no targets at the beginning set. Those targets were set with the countries in negotiations where after we had the commitment and the funding from donors, pooled funding, not earmarked. Those are really important issues if we want to have that shift from selective to comprehensive primary health care. And the other issue is that it's a matter not of coordination, but planning together and deciding the focus of what countries needs. Just to provide you an example, the other 7 countries work on maternal and neonatal issues. Costa Rica decided to work on a reduction of adolescent fertility. And that is one example of leadership and how important the definition of the problems is at the national, subnational, and local levels. So this is we are dealing with complex problems. And here we have very high level of outcome indicators. 11.4 reduction of adolescent fertility over 8 years in general. Yeah, in the 20 poorest percent of Costa Rica. And the focus and the approach was to have the Ministry of Health, the Social Security Institute, 3 agencies of social protection of Costa Rica, and the Ministry of Education working together. And needless to say that this was really, really difficult because it needed, some functioning, not structures, organizational structure, but functioning structures at the national, at the subnational, and at the local levels, because they didn't talk among them before this, setting indicators together, setting targets, setting and deciding budget, and especially deciding how the scheme of operationalize this at the local levels was really, really difficult. It took for Costa Rica like 2.5, almost 3 years to get, while working, yeah, but they didn't wait until having everything in place, but it took like almost 2 years for these coordinations. And once we all understood what the role and the financing and the responsibilities and how this was going to be operationalized, the next 6 years were really smooth in terms of monitoring, implementation, and accountability mechanisms, which are really important. This is only one example, and I have other examples like these ones in 8 countries in regards to quality of care, which is really difficult. When you discuss in terms of resilience, receiving the same quality of care with the same standards in good and in bad times, as you were saying, Lisa. And those are impact evaluation studies. Looking at in 8 countries, this is the baseline in the important contribution that Salud Mesoamerica made in these countries in terms of management of obstetric and neonatal complications. And there is even disaggregation looking at compliance, equipment, management issues, and etc. So what I think is really important here to note is that these countries, what they have done is to decide what they want to do, what is the change in the magnitude of the change that they are expecting, and to conform the teams. This initiative has not contributed or provided funding to have more workers, for example. It's having the same institutional structures and supporting countries to modify and to make changes in terms of the organization of the community outreach and incorporating issues as community platforms in consultation and cultural adaptability issues, for example, in these countries, working towards improving the health status of the 20% poorest populations. I think from the donor's perspective, it's also important to acknowledge that if we want to support countries towards comprehensive primary health care, we need to be ready to listen again to what the problem is. Usually we come and we think we know what the problem is, and we need to listen more to countries, to community, local levels, and also to re-questioning the problem, and also harvesting the local innovations. We had a list of innovations from our own, and the actual innovations that are being scaled up, not only one country, but in 8 countries, have come from the very local levels. And those are not sophisticated issues. Those are not sophisticated studies. Are things that are adaptable and that correspond to the problems in the knowledge of the local context and the dynamics of the community. So I think we have great examples of how these Mesoamerican countries have done. There are problems, but in general, I think we need to be ready to listen more, to set, to accompany those countries, not to lead the implementation and the decision of targets and strategies.
So I mean, you've said some really amazing things. I mean, I'm just sort of trying to set these examples in the kind of context of comprehensive primary healthcare. And it seems like what you're saying, if I've got this right, is that within a comprehensive approach, that countries can set priorities, not necessarily programs, of the things that they want to achieve, and that donors and funders must obviously, as you say, there must be planning for them to align themselves with supporting those local priorities, to listen to the local priorities, but within a comprehensive approach. So you're not setting up just another set of vertical programs, but you are, and also engaged in a very multi-sectoral way. I mean, you're a very good example of that. And is that right? That's kind of what you're saying?
Yeah, it's right. And also, it's like, for example, supporting countries to know how to develop a quality improvement strategies. You can start with some program, but the issue is how over time you will also support them to continue incorporating any other programs or problems. Is to learn how to do that for in a very comprehensive way. You have to start somewhere. That's true. Yeah, we cannot start with everything. And time is needed. These are programs like 10-year program. Yeah, you cannot expect in a comprehensive primary health approach results in 3 years. Yeah, which some of the donors want. Yeah, at the very outcome level indicator.
Great. So now I'm going to move on to our last question, which is maybe actually the most important question.
Can I just ask one? Just one quick point, because there's been a lot of discussion in the Q&A about the evidence needed. And I think what's interesting about the slides, Emma, that you just showed is that it showed that so for all the people that say, oh, if you invest in comprehensive, then more mothers will die because we're not focusing on some of the selective, that's the kind of evidence that's needed to say, look, if you strengthen the overall platform, in addition to the broader benefits of comprehensive, you will continue and actually get better outcomes from these more traditionally sort of vertically funded programs and including the areas in selective primary care. So really an interesting question. And I am not particularly an expert in dissemination and more effective dissemination, but how do you actually convert this into the evidence that a number of our attendees are actually asking for? So that's not asking for a response here, but thinking about how do we better use some of this emerging evidence to actually convince donors and policymakers and politicians that this is the way to go. Sorry for that.
Right. No, great. That sort of leads on nicely to the last question, which is essentially, so if we agree that we want to move towards more comprehensive primary healthcare, then what is it that we actually need to do? And of course, in the discussion so far, there have been quite a number of pointers towards the answer to this question, so we can go back and also highlight some of the things that have already been said. But I think actually I was going to come to you first, Lisa, for an answer to this question. So maybe we can, Emma, we can just stop sharing this for now. We can come back to it. Lisa, yes, what do we need to do? And you already started answering this question by saying we need to find a way of collating and presenting the evidence better. Yeah.
Yeah. No, I think it is an important thing. And again, I'm going to probably go a little bit more towards the comprehensive primary care and I completely agree with Prasanna about, is it universal health coverage? And it's not, I would just say UHC is not just financial, but it's also, it is also equity and quality in there. But really focusing on the health system role in comprehensive primary care. I think perhaps maybe that's another webinar for what's the role of all the other very important components for this. So I think, I always, being perhaps a little bit of an optimist, is to sort of say, what do we already know? And understanding, for example, lessons from the initiative that Emma just described, other work to understand where are countries going in the direction and what are the strategies that they are using. So often we talk about the innovations, and that's obviously very, very important. But until we actually think about innovations in delivery instead of delivery of innovations, I think we're going to constantly be stuck where we are. Sort of what's the next new thing? So, malaria vaccine is a really, really important new initiative, but it's going to require much more of a comprehensive primary care approach because it's not going to be integrated into the routine vaccination of children, of kids that are under the age of 1. So thinking about how do we make the argument and what is the evidence needed that comprehensive primary care, again, using a very limited health systems perspective and recognizing that we need to at some point go broader, that we need to understand what's actually working. So where, for example, is the community health worker effective? And so I think what we're really recognizing is they need to be salaried, they need to be supervised, they need to be supplied, and they need to be held accountable in the same way that providers are accountable. That we need to then figure out, well, why is that working, and for which diseases is that working? They're not going to do facility-based delivery, but they are going to be able to get women to come in for facility-based delivery. So I think we need to really think about what's working. I also want to focus on another thing that I think Emma said, which is this concept of quality. Because if all we focus on is reach and delivery, we're not going to actually get where we need to go. And we need to also think about quality beyond the technical quality, which is certainly the way that I was trained, to think about respect and experiential quality, to think about safety. There's nothing that COVID hasn't pointed out to us. It's that that's a very important component, and timeliness as well. And then finally, I think we have to figure out how is it that both researchers and government and implementers can sort of come together and figure out what is the evidence that's needed. How do they actually adapt to scale up or scale out what's actually already working? And then how does that get adapted for the specific needs of a country, recognizing that you need to also then listen to people. So we don't end up with 80% success, but the 20% that are not getting reached are the 20% that are most vulnerable. So I think it really is going to require a multidisciplinary approach. I think it's going to require us rethinking how we think about evidence and how we think about dissemination of evidence. So success is not a Lancet, is not a manuscript in Lancet, although that is obviously very important for people who need that for their own promotion. But it really is it in policy? How many lives is it affecting, and how is it changing? So I think we need to rethink.
So just because you kind of was sort of saying, how do we make the argument? How do we sort of present the evidence? But I mean,
and how do we learn better? How do we learn better from what's already working?
But I mean, like, I think pretty much all the governments of the world signed the Astana Declaration, didn't they? Was that 2018 or something, or 29? Certainly a significant number signed, and that, of course, is a sort of a manifesto, isn't it, really, for comprehensive primary healthcare. So are you saying that they didn't really mean it, or that it's the donors that didn't really get it, or that we actually do kind of want to do it, but we just need to know how in terms of the evidence?
I think it's really a combination, probably, of all three. I think it is. But I think that a lot of it is sort of how, and how is it that countries can learn from each other instead of necessarily from the experts who might be here on this panel, and how do we translate what are the lessons into something that's actually actionable? But interested what other people have to say.
So yeah, let's hear what the others have to say. So that's Lisa's answer to the question. So what is it that we need to do to better implement comprehensive primary healthcare? Let's see, Praveen, can I put you on the spot next?
Sure, Bob. I completely agree with Lisa in terms of evidence that needs to be generated. But again, taking a step back and looking what has been implemented, what has worked actually, and why is it what are the things that have not worked, and how do you actually fix those issues? I think that would be the best way. Again, going back to the example from India, when the National Health Mission was launched in 2005, many of these gaps were identified within the National Health Mission, which was again around narrow range of services, healthcare workforce, lack of medicines, limited referral services. And program was launched, which is the Ayushman Bharat, which typically completely focuses on delivery of comprehensive primary health. So it has been the services which were limited to 6 basic services and 12 services. Of course, implementation got issues, but still, there were efforts to increase the number of, to make the centers accessible to the population, so nearer to the population, to add in newer sorts of workforce, new layer with more dependency and who can solve problems or pattern was given a lot of importance. When we talk of comprehensive primary healthcare, and when we refer them in the tertiary healthcare and the systems where these people come back to the primary healthcare for continuity of care, then we are just overstraining both the primary, the secondary, and the tertiary. So I think these are some of the lessons that most of the countries have already learned. It's just taking a step back, trying to see what has worked, what has not worked, and then working on those specific gaps to develop solutions, I think.
Thanks, Praveen. So you broke up a little bit at moments there, but hopefully your connection is back. Rahina, do you want to add anything to that?
Yeah, actually, I just want to add the important bit of funding. I think each country has to invest more in primary health care. However many declarations they might sign, until and unless there is money to support health workers, there's money to have essential medicines, there's money to have the infrastructure and the equipment required for providing right from sanitation, water, through to medication. I don't think evidence or any evidence-based intervention can be implemented without that. So that's the difficult bit, but I believe the most important bit.
But I think, I don't know whether it was Emma or Lisa that earlier on, there was also making the argument that it's also using the money that you have committed more effectively to support comprehensiveness, as well as potentially also putting more money into primary healthcare. Yeah. Emma, I'm sure, I think you wanted to, I saw you had more slides and you probably want to add more. Yeah.
Yeah, just what I have seen and learned from the 8 Mesoamerican countries and how they have been doing this, what they have done differently, I think, is the first issue was setting subnational targets, not only national targets. That is really important for the teams at those levels, and to relate and know exactly what is it, what each network or each geographical area in the network of communities want to achieve. Also, the external and internal evaluation and measurements that supported to improve the administrative systems and routine information systems. And another highlight is that these countries have been measuring to act. It's not only measuring to report, which is really important. It is obvious, but it's not always what happens. Yeah, and this is one area: the targets, measurement, and measure to act. Another things that they have been doing different is that they set a systematic interlevel accountability mechanisms from central to the subnational levels and vice versa to the local levels and among countries and between and within countries. And I think this is really important, including the alignment of incentives. They have tested and proven the use of economic incentives and reputation incentives and other types of incentives with the health teams. And that there is data about that supports the improvement of health outcomes when you align the incentives within the system. The adaptability and the constructive destruction of what they have learn while implementing in the multisectorial approaches. And lastly, I'd like to talk something about how at least these 8 countries, based on experience, how they have been learning. And we have supported them to have systematic and intentional collaborative sessions within and among countries, where they have shared the lessons, the experiences, the failures, and the success. And that is really important. And they have also shared the innovations and how they have worked and what have not worked for each one, depending on the context. Also, another important change has been the way of supervision and how this has changed from the punitive approach to a more like, coaching, accompanying, and mentoring the teams. This has been a really hard change over 8 or 10 years. And because culturally, we are used to, to look for the responsible and to blame the responsible person. And so this is really important, going to coaching, to mentoring, to the lens of quality, continuous quality improvement, and having these rapid learning cycles and using, without sophisticated evaluation and studies, improving their own tools. Those are the lessons I have seen during the last 8 8 years that
there's
these
some
8
real-
countries have been applying.
Some real pearls there. I mean, you just gave us a list of about 8 different things that you have found to be effective in Latin America. That's brilliant. Thank you. How are we doing? We've got about 15 minutes left, and I feel like we should use the last 15 minutes to do some justice to the remaining questions in the Q&A and on the board. And Manushi, I need you to help me with this. Let's see if we pick out 1 or 2 things that we should be looking at.
Right.
So,
No new additions on the Jamboard from the last time, but I see
okay.
Q&A is more
So I'm
active.
just going to pick up some of the comments and questions. So I see that Chering Wangdi asks, is the initiative for comprehensive primary healthcare an effort towards revolutionizing the traditional approach to primary healthcare? Would countries in low resource settings afford it? And something benefits, I think it's made, and benefits with the health. So there's actually another question really about, is this just too radical an idea, and can low income countries really afford comprehensive primary healthcare? Is this just some utopian dream, you know, amongst people like us? So who wants to, I know we did address that a little bit earlier on, didn't we? But you want to have another crack at it? Praveen.
Sure. No, I mean, yeah, this is an interesting question. And are we really looking at comprehensive primary healthcare as something novel that we want to implement, or is it a continuation of the health services, expanding the existing health systems to make sure that it is comprehensive? So, so again, examples from many countries, India, Indonesia, especially if I can talk about India. The new program, which is the Ayushman Bharat, sits on top of the National Health Mission. So it's not reinventing, it's not reinvesting, it is just expanding whatever we have from NRHM. So from the National Health Mission, we have a very good network of hospitals. We have a very good infrastructure. We have good health workforce. There is training. There are service packages. So in the new Ayushman Bharat, all of this were expanded. But of course, it's not easy. Expansion of any services or implementation of the comprehensive primary healthcare will need some sort of change management in the processes of planning, in service delivery, in monitoring, in financing. And this will also require a lot of participation, you know, active participation of several stakeholders, civil societies, NGOs, academic and research organizations, development partners, the private sector, and most importantly, the community. The community should not be forgotten, and they need to be, you know, given a major part in this change that we would need to see.
So thanks, Praveen. I also got a slightly different question for Rahina. So I think this was the subject of your research project, is, you know, like, I mean, who do you actually need in the workforce to deliver comprehensive primary healthcare? I mean, I know the conversation in South Africa is the conversation that I'm trying to have, you know, saying, well, yeah, on the one hand, community health workers can certainly increase reach and coverage, but they don't necessarily increase quality to the extent that one would want. You know, South Africa is wanting to introduce national health insurance, which means that people have to believe in the quality of their primary health care that they're going to be getting. You know, one of the arguments here is saying, no, shouldn't there be a family doctor part of every primary healthcare team in some place? So not delivering primary healthcare as the frontline person, but being a part of the team to, you know, improve the quality at the sort of community ground level. So I'm interested. What's your take on who's needed? Is there an answer to that? You know, what's the minimum needed to deliver on that? Yeah.
I think it's a team needed. So it's not just a community health worker or a nurse or a doctor. First of all, doctors are just not available. We all know that be it South Africa or even Australia, rural Australia, there aren't, doctors don't want to live out there. There are just no doctors available. So I think if they could, like India or many other countries, South Africa has that model of having community health workers, nurses who are more sort of community based, but then a doctor at the primary health center who is that quality check reference point. And that team works together to provide comprehensive primary health care. Now, that might not be at the primary health center. They might be located slightly further away. And there we can bring in interventions which are already now in place, like digital health tools, telehealth, linking primary, the community health care workers with doctors. There are so many, studies and there's evidence, but just as Lisa said, it's around the, how do you, what are the innovations in delivery of these evidence-based, interventions. So I guess it's the team, Bob, answering your question, and it's not just the community health worker. And just the other thing of, we are putting so many things on the community health worker, so I think it's also time for us to kind of see, all right, what's working, just as Lisa and Praveen said, and we've got to remunerate them. We have to support them. And Emma, as you said, accountability checks shouldn't just be, well, why has this occurred? But, well, how can we support you such that this doesn't occur again? I would love to see that.
Thanks. So Manushi, I'm just hoping that you can lift out one or two questions that we haven't addressed yet from the Q&A.
There was a question around health information systems.
Right, yeah, go for that one.
If I could just initiate.
And then Manushi can be picking out one or two. We've got about 10 minutes, 8 minutes left. Yeah.
Quick response to that. Absolutely essential, Karen. Thank you for that question. I think health information systems, not just in terms of electronic health records, but basic information systems about births and deaths. How many people are dying? Who is dying of what? 60% of people in low and middle income countries are born out of hospital and die out of hospital. They're not recorded. Their causes of death are not recorded. How do we provide comprehensive primary health care if we don't know what people are dying of? So I think health information systems, again, need the comprehensiveness in that is also needed. And I think countries are working towards that. But how do we kind of bring that together such that we can, embed patient identifiers and electronic health records as well? Thanks.
If I could just add, I think really, really important area. And I think it's again, this idea about how do we make sure the data are good enough. So this is not perfect data. This is not research data, but it really does need to help. And what are we measuring? So how are we integrating in measurement around quality? And then some of the work that Karen's aware of, I'm sure, and others around, some type of harmonized assessment so that countries can learn from each other because they're measuring the same thing the same way. And then very importantly, what do we know about strategies that work to increase not just the data production, but the data use to drive and inform change? And I think, again, some countries, I've spent a lot of time working, learning from Rwanda is a really great data consumer, but other countries as well. Senegal is another one that we've learned a lot from, but also I know some of the ones in Latin America is also equally important. So I think it's not just the data in, but it's also what you do with it.
Thanks. I just see in the chat that I think Prasanna is sort of coming back to definitions right at the beginning and saying we need to delineate between primary care, primary healthcare, and comprehensive primary healthcare. I'm going to have a stab at answering that and see if the panel agrees with me. I think we're kind of saying that primary healthcare, by definition, if we take Astana and what the WHO are currently talking about, is comprehensive primary healthcare, and that it means, and they've got these three important areas that they've highlighted in their recent publications. The one being multi-sectoral policy and action, which we've also talked about and given examples of. The other being sort of empowerment and engagement with communities, which we have actually not spoken so much about. And then the third was, the delivery of primary care, with essential public health functions. And I think, when you look at the WHO's measurement framework for primary health care, you'll see that within primary care, they also have one of its core functions being comprehensiveness. So there's a sort of, I guess there's a big C, comprehensive primary health care, which is everything. And then there's a little c for primary care itself, that must also be comprehensive, in terms of the life course and the range of services and the burden of disease and so on. So that's kind of how I'm formulating it in my head. Do people agree? I see Rahina's nodding, that's good. Everybody looks like most people are nodding. And Lisa's smiling, so that's good. We've got about 5 minutes left. Actually, it's interesting, we haven't talked a lot about that aspect of community engagement, participation, empowerment, and so on, as an aspect of comprehensiveness. And how do we actually do that? Maybe that should be a question we spend a minute on or two. Anybody, any takers for that one? How do we do better with that? We're not doing well in South Africa, I can tell you that straight off.
Yeah, maybe I can have it start, Bob, again here. So yeah, I mean, community engagement, there is no way apart from, away from community engagement. It is essential, it is the need. But again, taking a step back and understanding why, what kind of engagement do you need with this community? Would it be for social auditing of your primary healthcare facilities? How the services are running? Would it be placing some of the responsibilities of the primary healthcare in terms of sanitation, in terms of healthcare access back onto the community, or whether it is, involving them in the decisions when we want to implement newer strategies for any primary healthcare interventions. So this could be wide varied involvement of the communities, something to think about.
Yeah, I think, certainly South Africa during the COVID pandemic, we really felt the lack of community engagement in the way that we, were not able to take communities with us, to kind of get buy-in or to invent appropriate sort of public health measures, and resorted back often to quite sort of authoritarian and punitive ways of handling those measures. Yeah. Anybody else want to weigh in on this in the last minute or two, or come up with a final comment?
I guess this is my final comment is first of all, thanking everybody who came, and to come and sit on a 90-minute webinar in this era is really quite remarkable, in the sense of clearly how important this area is and how many unanswered questions there are. So I apologize that we certainly don't pretend to have done that, but we're going to keep all the Q&A and figure out a way to sort of address those types of things. I think, for me, it really is, getting some clarity. I think that that we need to figure out how to better capture and disseminate the learnings. And I'm going to end with a response to Hensa Desta, which is this very important thing about comprehensive primary healthcare in an equity lens. And I think it's really critical to recognize that if we can't actually reach the most vulnerable person in the most hard to reach with this type of comprehensive care with quality that is people-centered, then we will have ultimately failed. It is a challenge when we use averages, when we use means. And even when we look at improving quality, often it's the people who are sort of the most privileged who are raised the first. And so I think keeping an eye out that we always need to put an equity lens, whether we're talking about primary care, comprehensive primary care, whatever is really important. So I'm gonna end with an equity push.
That's great. And I'm going to give it, we've got about 30 seconds each for a final word. Rahina, your 30 seconds.
Well, bringing in the health workforce and taking care of them, training them and equipping them. Thank you.
Thanks. Emma. Oh, you're muted.
Community participation and engagement, especially among indigenous populations and cultural adaptability, and also trying to implement results-based financing programs, looking at alignment of incentives, not only financial, but also other type of incentives in the system. Thank you. Thank you for the invitation.
Thanks. Praveen, last word.
Yeah, thanks, Bob. So, well, the last 30 seconds, I would like to take a reflection back from this meeting, which we have not covered, unfortunately. Private sector caters to about 70% of all the OPD services, at least in India. And how do you talk about comprehensive primary healthcare without involving the private sector? So maybe this is something to talk about. Think about.
That's a big debate, maybe for next time. Manushi, I'm closing there and handing over to you. I don't know whether there's anything you want to say by means of closing the webinar.
Sure. Yes, this is the most exciting session that I've attended in a while, and no presentations involved. Yes, I will share the recording with everybody, and hopefully we'll be able to come up with a blog as well. So stay tuned, engage with us on our Twitter handle. We're very active over there.
Great. Thank you, Manushi. Thank you, everybody, for being here and for participating. And thanks to the panelists, of course, especially. Bye for now.
Yes, bye for
Thanks,
now.
Bob.
you.
Thank you.
Another 4
Thanks,
webinars
thank you.
planned, and we'll
Thanks,
keep you
Bob, for
informed.
fabulous keeping all the cats moving in the right direction.
Bye.
Bye.
Bye-bye. Bye-bye. Thank you.
Bye-bye.